A very good evening to everyone.
Good evening, good evening.
Hi, Louis, ma'am.
Good evening,
Good evening, Dr. Latika.
Good evening. Hi, Angela, ma'am. We have a speaker today. I'm just waiting for him to join. Dr. Steve, a very good evening.
Evening, Doctor.
A very good evening, sir. So you can share your screen. Doctor, I cannot see you. I'll just disable the chat so that later you can take your questions. No problem.
Good evening, ma'am.
Hello. Hello, doctor. Thank you
Am I
so much
visible
for
now?
making time. I know you're flying to India, then you're back to your country, again coming back, moving on to a lot of places. But thank you so much, doctor, for being here. Allow me to just introduce yourself and then you can take over. Okay? So
Thank you very
greetings
much.
to all. On behalf of IIBM Institute of Business Management, it is my pleasure to extend a warm welcome to our esteemed speaker, Dr. Stephen. Dr. Stephen
Thank you,
is an
ma'am.
accomplished hair care leader, CEO, gynecologist, whose remarkable journey in transforming the rural healthcare service through technology adoption, strategic leadership, innovation, and an inspiration to professionals across the industry. We're truly honored to have you, sir, with us today to share your valuable insights and real-world experience on building sustainable organization, even retaining clients, and driving growth through visionary leadership. So, Dr. Stephen, thank you for joining us. We warmly welcome you today for our Corporate Talk series and look forward to learn from your experience and expertise.
Thank you, ma'am. It's a pleasure. Is my screen visible?
Yes, sir, your screen is visible.
Thank you very much. So, my name is Stephen, and I'm going to give a talk on technology and innovation as a growth engine for rural hospitals. And I'll give a case study of my hospital, which is Nakuru Specialist Hospital, which is located in Kenya. So my biodata, I'm a co-founder and CEO of Nakuru Specialist Hospital, and also a consultant obstetrician gynecologist. And also I am a student of DBA in health and hospital management under the supervision of the distinguished professor, Dr. Latika Shadberg. And I hope this talk is going to be useful. So the talk is a case study of a rural or small city hospital, and I believe it's generic. The issues are generic to any business in a rural place. So the format of the talk, I'll give us brief context of Nakuru Specialist Hospital, a brief history. I'll give a strategic outlay of the hospital, execution of the technology strategy, and comparison of adoption in developed and developing countries, and justification and a business case for adoption of technology. And remember that this is, I believe, in my opinion, very transferable to any business in a small town or a small city or a rural hospital. So Nakuru Specialist Hospital is a referral hospital in Nakuru City. Nakuru is a tier 2 city. It's 150 kilometers from the capital city of Nairobi. And this is important because it is very accessible to Nairobi city, and therefore patients sometimes really opt to go to Nairobi for things that we can do for them in Nakuru. So it started in 2019 by a group of doctors. Initially started as a 40-bed hospital, but now has grown to 100-bed. Started with 40 staff, now has 300 staff plus visiting doctors. And currently we have 6 operating theaters. Initially we were only 2. So we have 4 which are dedicated to purely maternity, 1 for endoscopy, 1 for laparoscopy, 1 for orthopedics, and we have 2 shared between general surgery, neurosurgery, ENT, pediatric surgery, and we have a school of surgery. So the executive thesis is that a rural hospital, and I believe any rural business, grows fastest when technology is treated not as an isolated equipment purchase, but as a market infrastructure. For any rural business to catch up, then it has to invest in technology. So for us, technology adoption creates a clinical differentiation, and services which were previously only required in the big city, for our case, Nairobi, or any big urban referral center, then can easily become local to any rural business or hospital. And advanced methods create reputation. For us, it was laparoscopy, which is minimally invasive surgery, IVF, and modern theaters. And what this has done is to shift the brand from a small city or small rural general hospital to a region center of excellence. And we give a 5-year strategic horizon with a platform model which offers a core growth mechanism. So the reality of any rural business is that the opportunity is not only clinical, but it's a market design problem. And there are 5 areas that we identified as problems which need to be solved. And the first one is access gap. For a hospital, the limited access to specialized care, referral burden to urban centers, where if access is good to a big city, then people opt to go to the big city. But there's an opportunity here. There's also a talent gap where there's low retention of skilled clinicians, where case mix and training pathways are thin, and people will opt to go to the big city. There's a perception gap, the proverbial prophet without honor at home. And we see for hospitals, most rural hospitals will be seen to just provide basic care only and are not able to provide any other care. This provides another problem of economics gap where underutilized theaters, low case volumes, and low volume services suppress the margins. And the learning gap, I believe, for any rural business, for us at the hospital, is that the learning gap is quite steep. And without a training pipeline, then technology remains just dependent on a few champions who, if something happens to them, then things crumble. Now, for the market discussion, why rural businesses stagnate, and if I frame this in a doctorate level framing, is that the demand exists. But if the demand is so big, then what are the problems? And for us, there are leaks through referral, there are problems with trust, there are capability asymmetries, and we can put this in 5 big problems. The first one is the demand leakage, because patients will see that access to a big city like Nairobi is easy, and patients opt to go to Nairobi or other big hospitals. There's a capability asymmetry where the highly specialized people, doctors, then will concentrate where volumes are big, equipment outlay is good, peer networks exist, and certainly there is better pay. So that creates a very big problem for rural hospitals. There's also a fixed cost trap, because all the infrastructure, the modern theaters, IVF labs, IT platforms all require big volumes to break even. And what this does is that it dissuades the rural hospitals from setting up all this infrastructure. Then trust deficit. Everybody thinks that the big city is bigger for certain things, and for us it's Nairobi. India is a popular destination for a lot of people seeking care. Then the other problem is that there's a talent flywheel missing. If there are no local training ecosystems, that means that improvements do not occur as fast as they should. And from a strategic point of view, then investment in technology needs not to be done as a standalone equipment, but it has to be done as a service line platform supported by training, by referral capture, by data, governance, and certainly by a lot of patience. What does technology adoption and sharing mean? It means that this is what a rural hospital will need to drive its growth engine. And it's not linear, it's a cumulative aspect of a combination of things. Advanced model method, train the team, generate volumes, hopefully enough to cover the ROI, measure outcomes, then build a market trust, attract talent, including the highly specialized specialists, and reinvest. And we do this by sharing mechanisms, specialist referral network, shared training and simulation labs for theater teams, shared outcomes, dashboards, and protocol libraries, shared fellowships and visiting surgeons rotations. And what this does is that higher case complexity is able to be done and retained locally. There's reduced outbound referrals, and lost revenue is minimized with improved patient loyalty. And the patients who are sorted out in our hospitals are the ones who are going to tell their relatives, their friends that this service is actually available in our small city. Also, there is more predictable staffing pipeline and evidence for insurance and employer contracts and justification of why insurance or other employers can trust smaller rural hospitals with care. If we do a comparison of the developed world, developing countries, and least developing settings, then we see that they will adopt technologies for different reasons. For the developed countries, the electronic medical records, virtual care, analytics, AI pilots, they are actually big on that. And what this does is that there is improvement in productivity, higher quality, chronic care integration is better, and they have aging populations which need chronic care. And there's a lot more home-based care than hospital-based. For the developing countries, then there's mobile first, private innovation, telemedicine, and high volume specialty models. And what these do is to leapfrog to a digitally enabled specialty hubs and affordable advanced care. But this creates a problem of interoperability, financing, and even skills and infrastructure. Now, for hospitals in places like which are least developed or developing, then we see things like targeted high impact technology like drones, digital tools, and referral networks. And what these do is that they solve bottlenecks where infrastructure is a problem. We have problems with connectivity, we have problems with computers, but the typical constraint is connectivity, because internet is a problem, computers are a problem, a lot of donor dependency and maintenance and local capacity. Now, for a hospital in Nakuru, then what we needed to do was to emulate all the advantages of the developing, and least developed, and see what could work, and adopt for the developed countries good governance, especially with clinical systems and data. Then adopt the things which work for the developing countries like India, and that will be a cost discipline. And for the least developed countries, then self-frugality in choosing the bottleneck solving technologies, and just keep picking the best from each world. So the evidence base for our case, we started with what we consider low-lying fruits. surgery. WHO estimates that about 5 billion people lack access to safe and affordable surgery. And what this means is that if any hospital adopts surgery as a strategy, then there's a good case for good business. There's a big problem of referral leakage. And the rural hospitals leak a lot to the big cities, and that provided an opportunity. What has worked where? For if you just look at a few examples of the developed country models, if we look at Estonia, we look at the Kaiser Permanente and EDSH, then we see that they are very big on electronic health records and e-prescriptions. And what has worked in those countries is that health data and prescriptions are linked to care improvement with chronic care management and data use. So they are very big on integration of data. For others, is that there's more emphasis on home care for some selected pathways, but all this use just to relieve bed and extend reach. For the developing country models like India is big on this. We see a lot of innovation, and one of them is telemedicine, which helps to reach very large volumes across many states. We see high volume tertiary care with a very deliberate process standardization and focused volume to reduce costs. We see high quality and affordable, which is a misnomer because high quality usually doesn't go with affordable. But we see if processes are industrialized, then there's a possibility of making standardization and repeated surgeries and outreach demand creation. If we specifically look at Akanksha type Indian model, then we see their modular operating theater, laparoscopy, and IVF. There was investment in advanced infrastructure used for visibility of specialty positioning, and this makes a case for rural or mid-tier hospitals to use technology to just grow one specific part of the brand with all the supporting components of it. Coming closer home in Africa, we see Rwanda and their zipline. And basically what Rwanda does is that it delivers blood products by drones. And this helps to reduce delivery time. This reduces blood wastage. And there's a lesson for us is that shared logistics capability across facilities. Ethiopia with this digital blueprint, there was a problem was that there was fragmented digital health architecture, but the national plan emphasizes interoperability, governance, and capability, which is largely driven by their government. But the lesson for us is that there's need to build architecture before buying more systems. For Bangladesh, there was a digital consultation, which was used to bridge rural-urban doctor gap, where doctors prefer to stay in the urban areas, but the rural areas also need doctors. So telehealth must be paired with visible local nurses and reliable referral chain. So the adoption pattern is that a constrained infrastructure makes for shared platform more valuable than just isolated facility by facility purchase, and this makes it a bit easier for adoption of such technology. So coming back to Nakuru Specialist Hospital, the hospital was already ready to become a rural center of excellence. And this was seen in clinical breadth, good outpatient service, where we see more than 200 outpatients, big outpatient capacity of more than 60 per day. We have a strong surgical component and a strong maternity component with a good ICU and HDU support for the critical care component, and with a good support of imaging and also laboratory services.
बिल्कुल पैसे रखे हैं तुम्हारे पास?
And the hospital is
Sandeep
strong
sir,
on
please
surgical.
mute yourself. Sorry, sir.
Sorry.
Our hospital is quite big on the surgicals, and we actually aspire to be the biggest surgical hospital. We started this with laparoscopy exposure. Laparoscopy is a minimally invasive surgery, which is the future of surgery. There's also specialty adjacency, where we have all the specialists on close proximity to each other: gynecology and fertility, urology, general surgery, and specialized surgery. And all these are able to support each other so that care can be given under one roof. So now, for us, the growth thesis was to move from just service breadth to specialty depth, where minimally invasive surgery, IVF, training, and digital command could all integrate into one big piece. So as a strategy, the hospital started with the laparoscopy surgery, which is minimally accessible surgery. And this was our first differentiator. We were the first to do large-scale laparoscopy in Nakuru, our city, and also the larger region. And what this did was to create clinical value. Patients saw faster recovery, smaller wounds, shorter admission, and low infection rates in selected operations. And this created a market value for us, where we created a premium service line, which reduced patient linkage to Nairobi. Now, it's important to just mention that this took a while. Many patients could not believe that laparoscopy could be done in Nakuru, and will often go to Nairobi, where services were readily available and obviously more expensive. And it took time before people actually accepted that Nakuru can actually do laparoscopy. Then with that, we did a scope expansion, and we started with the easy pickings, gynecology and general surgery. But then eventually we did urology, we did endoscopy, we are now doing neurosurgery and selected bariatric pathways. Now, the critical control point of all this is that the execution requirements require credentials, they require protocol development, they require simulation training, and outcome audits, which are largely done by a board of management, which is extremely supportive of our activities. The second growth pillar is a modern theater complex, and this was in way of a modular operation theater. Was quite expensive to do, but the board was convinced that we do a good job, and for 10 to 20 years then we will need to do another one. And this modular theaters has laminar airflow, which is basically a one-way airflow to reduce infection, with HEPA filtration to reduce infections. There's a zoned flow and patient and staff flow, which is very well designed, and also supplies. We have also attempted to integrate imaging with screens and digital video captures and telementoring readiness for our hospital, with an integration of CSSD, which is basically sterilization of equipment so that we don't get infections. So the third growth pillar that the hospital adopted was IVF and advanced reproductive services. Some of these things are still work in progress, and we believe that there's a big demand for fertility care. So there's a business sense for us to go into that aspect of business. And the operational logic is that IVF creates cross referrals, where patients will be sent into ultrasound, into labs, into theater and pharmacy, and all this supports a bigger picture. And the market logic is that we need to position ourselves as a regional fertility hub, not just as a procedure room. The fourth pillar is the Nakuru School of Surgery, and here we aim to convert technology into an institutional capability. And we are doing this in a simulation lab, where we have laparoscopy box trainers, we have endoscopy trainers, We have developed or in the process of developing a curriculum for theater safety so that we can train theater technicians and also doctors. We are in partnerships with local universities. We have Egerton University in Nakuru, surgical societies, the Pediatric Surgical Society, and also the Urology Surgical Society. And we have Indian mentors and also visiting specialties. And we believe that all this will affect our brand, because training attracts specialists, and specialists attract patients, and patients attract business in a sense, because now insurance will also want to come in. So for us, the school must be part of a production system for safer surgery and not just a mere room. The fifth pillar is IT and digital health. Again, this is also work in progress, and we are currently doing electronic medical records, and we want to integrate billing, pharmacy, scheduling of theater and clinics all into one performance spine, and with an ability to do dashboard for utilization of our services, our turnaround time, our outcomes, and very important for the shareholders and also for the board is a revenue cycle. And for the clinical part, then we need to know our referral source and also get patient feedback. So all this is work in progress, and we are embarking on this step by step. So the other aspect of this pillar is that we are in attempts to do data governance so that we can access controls, we audit trails, and we make sure that our downtime procedures and cybersecurity drills and consent protocols are in place. So for us, we keep asking, what will a board ask? What will a board of management ask? And for us, it's the same truth. Does everybody see the volume? Does everybody see the quality that we aspire to? Revenue growth, which is important for the shareholders and investors. For the clinical aspect, safety, the referral leakage, and how we are preventing it, how we are minimizing it, and the general patient experience, how is it going? And for us, it's very important that the board sees all these things in one voice. So the sixth pillar of growth for us will be a fellowship for both surgeons and also for our theater technicians. And we intend to do minimum access surgery. We're already doing part of this in both gynecology and also infertility, and also endoscopy and general gastrointestinal surgery, because we have the capability to do that, and also perioperative leadership. So for us, the design principle is that every fellowship must be tied to volume, a logbook, competence for the clinical aspect, patient outcomes, for the patients to get better, but also for the shareholders. Then what do all these pillars contribute for our revenue contribution? Now, for the evidence base, digital health is now an infrastructure. It is not an option anymore. And digital health has moved from a nice to have component to a core determinant of health systems readiness. And WHO is of the opinion that this is where the next thing is going to. So for us in Kenya and Nakuru, the strategic window is that the national policy is shifting towards integration of data, and the Kenya Digital Act creates a legal architecture for health data governance and secure health information exchange. And this brings aspects of access to data of patients, but also data privacy, and all these are important things. So for us, it's an opportunity to combine compliance with visible clinical innovation, advanced surgery, IVF, digital workflows, and trainings which work for both the patients and also for the business sense. So how we see this technology sharing architecture is in a hub and spoke growth model, where we have a referral doctors as one aspect of the hub, telemedicine network, our cooperation with county hospitals and private hospitals, and surgeons, fellows, and also theater technicians. All these come together so that we can have shared assets in terms of teleconsultation, referral protocols, outcome data, and simulation labs, and also visiting surgeons. So now, in terms of implementation, we did this in a 5-year strategic plan. And in year 1, we were big on stabilizing and digitizing our operations. And we started with laparoscopy. Then year 2, we wanted to differentiate clinical services. And here we introduced a lot of general surgery work and gynecology laparoscopy expansion with telemedicine, and a theater utilization dashboard and a training lab setup. Year 3 is just building the platform. When we built the theater complex, which was very central to our strategy, including a School of Surgery and fellowships pilot. Then year 4, we went to launch an advanced reproductive hub of IVF. And year 5, we want to see if we can scale this regionally so that we can create a big system for ourselves. Now, the roadmap comes with measurable milestones of yearly, between up to 12 months, up to 24 months, 36, 48, and 60 months. And this go into phases of clinical, digital, people, and market. And we realize that all these are important because a hospital exists primarily to give clinical care. So we need to have safer programs. We need to have low complication rates. Digital, how do we integrate our core systems? How do we have dashboards which work for the hospital, which work for the shareholders, which work for everybody who needs to look at things, how things are going? Then, of course, people. We are big on building people. We are big on credentials. And here we did the simulation lab, the School of Surgery launch, how we train people, how we just work with other people, how do we expand what we are doing, how do we have a faculty and visiting surgeon network, which works for both the hospital and for the surgeons. Then, of course, ultimately, for the shareholders, they're interested in the market. How do we make a business sense of all this? How is the referral leakage baseline? Are we reducing? Are we stagnating? Are we improving the leakage? How are the packages working? Are they working for the third payer insurance? Are we able to do a brand campaign which works around certain things like the theater complex? And all this become very important. And all this integrates into technology. Of course, there were expected problems, both clinical and operations. And for me as a CEO, I sit in both. I'm both a clinical person. I'm also in operations and management. And there are all these problems which we needed to anticipate and see how to handle. The first one, which occurs all the time, is early complication anxiety. And we have anxiety everywhere. Are these visible high trust services? Are we able to do them? Are we as good as a big city? The other problem that we faced was technology underuse, where staff revert to manual habits when systems are slow or are poorly designed, or they don't understand, or they're not able to fix problems. The other thing is theater bottlenecks, scheduling, our sterilization unit, our anesthesia, our recovery. What happens if they're not synchronized? Maintenance downtime, what happens when the special equipment require planned service or spare parts? A lot of our equipment comes from abroad. What happens when something spoils? Are we able to quickly get it fixed? Our quality drift. We anticipate to have volume growth. What happens to the quality? Are we able to still give good quality even as we are growing? And all this became problems that we needed to know how to handle. When we sit in the boardroom, the issues of finance, the issues of market, the issue of governance, the risk of capex stress when we have capital expenditure, which obviously initially outweighs what we get in return. How is that sorted out? Do we lease equipment? Do we rent? Do we buy? Low initial demand. We have a big theater. We have all these services which initially people don't believe that they can work. So what happens when the initial demand is very low? The digital divide, patients who cannot use telehealth or portals, data breach and privacy breach, which in our country is very big because we have had a lot of court cases where data breach have happened and it's been a problem. And the mission drift, because we have always to stay within our mission. And these have all been problems which have needed a lot of conversations back and forth until we got solutions. And in all this, we had, whether formally or informally, a mitigation playbook in all the phases of our adoption. Before adoption, we had to build business cases for the different aspects. We had to build protocols, whether formally or informally. We had to have a training plan, maintenance plan. During adoption, the support that we needed, the daily hurdles, the daily problems. Were the managers adequately positioned to sort out incidences and problems? Are we able to respond to patient feedback in our systems? After adoption, we had outcome registries where we could look at how the outcomes were and board reviews to see how things were going. Were the third payer contractors happy with ours? Were we happy to do service expansion gates? And also external audit and peer reviews. And in all this, the red line controls, and I appreciate my board of managers because they were always there to just see if things were working. If things were working, then they will be upscaled. If things were not making sense, then some schemes were actually just killed. So the governance principle all along has been that technology adoption is a clinical change management program and not just a procurement program. So, and it is always an ongoing program. So all these had KPIs in terms of access to referrals. For us, big on surgery, are we able to do a good case volume? And we have grown. Our conversion rates were good. Our complication rates are lower and they are still decreasing. Are we able to train simulation? And we have had to prescribe simulation hours and log boosts for our staff with competence sign-offs. And also, ultimately now, finance is that there's important to see how the utilization versus the break-even was working out. So financial logic from capex burden to a platform economics, and every investment, which all the shareholders need to know is that the investment must feed into multiple revenue streams so that the return on investment makes sense. For us, the theater complex was able to support laparoscopy, was able to support urology, was able to support neurosurgery, endoscopy, training, visiting surgeons, and also premium care packages. The digital spine, still work in progress, but it's able to support billing accuracy, claims to insurance, turnaround time, referral capture, and patient retention and operational control. The School of Surgery and Fellowships, where we have reduced recruitment dependence on external while just generating fees and prestige, and also a surgical volume. A school is always something good for a hospital because it improves our credibility. IVF hub, work in progress, to create repeat diagnostic and multidisciplinary care, not just one embryo transfer revenue, but to link with the lab, to link with pharmacy, to link with the clinics, to link with theater, so that it multiplies the multidisciplinary care. So it's very important that every technology is within service line, has a service line owner, has a utilization target, has a maintenance plan, and a quality metric and a patient acquisition pathway. So the strategic vision from rural hospital to a regional center of excellence has 4 components. The clinical center, for us, we are already recognized for minimally invasive surgery, IVF and advanced theater capability in our region. Digital command, data-driven decision across quality, turnaround time, revenue cycle, and referral pathways. Training institutions, as I mentioned, that are School of Surgery and Fellowships create a local talent flywheel and a regional platform. So the closing message is that rural hospitals and indeed rural businesses do not need to remain basic. With technology, training, discipline, governance, they can become credible centers of excellence. Thank you very much. And these are my references and evidence base.
Thank you so much, sir, for the lovely presentation and explanation. We have few questions. Yes, Ajay sir.
Yeah, so good evening, Dr. Atika, and good evening, Dr. Steve. So, Dr. Steve, I am having a question to you. Regarding the Nakura, there are the 3 hospitals are there. One is your specialty hospital, one is the Mary Stopes, and one is the Prima Care. The total patients annually are 3,000 to 8,000, those who are planning to do the IVF. And as per the potentials, patients are there, it is coming only 50 to 200 patients per year. How you are going to position yourself? Question number 1 on the IVF. Second, the question number 2 is regarding the PGD. Are you doing the gender selections and all? Like the PGD, you have not been informed. And the third is regarding the HIFU and HICU, like the hysterosomal self-angiography for tubal patency test. So these are the other things have you added regarding the competition, looking into the Mary Stopes, which is a well-established one. Thank you, doctor.
Thank you for that question. Our hospital is a multi-speciality hospital. We are big on the surgeries. We are big on gynec surgeries and orthopedics, general surgery. We do neuro. We do pediatric surgery. We also do urology. We also have maternity. We have general. It's basically multi-speciality. I know Maristops largely does gynec, and it's not a hospital; it's a clinic, so it's a patient, an outpatient facility. I don't know if that has answered your first question. The other hospitals in my country, most hospitals are multi-specialties. We don't do like the Indian model where they are monospecialists. It is usually multi-speciality hospitals. Now, regarding IVF, we are just starting. As I said, some things are actually work in progress. We've started some fertility surgeries like laparoscopy. We are doing hysteroscopy, and we intend to eventually move on to PGDs. If I've answered the question.
Yeah, thank
Sir?
you. Thank you, doctor. Because I worked in the IVF center in Dubai. So I'm having a good rich experience of marketing the IVF. So from the PGT, IVF, XC, TSA, PESA and all this thing. That is my question was there, is it just a suggestion if they can add the TSA, micro TC and all, I think, and DNA fragmentation, it can just generate more the revenue. This from my outlook perspective. Currently, I'm working in a hospital, prime hospital, in Dubai.
Okay. That's actually a very interesting observation. In my country, we have about 12 IVF centers, and we don't have any in my city. So we are the first ones who are going to do IVF. So for us, it's an opportunity. There's a big demand in this part of my country to do IVF, and we'll certainly introduce all those. I've been trained by Akanksha Hospital in India, and they do all those highly specialized IVF procedures. So we intend to have all of them, and we have very good mentorship from Akanksha. So we are able to introduce all those. Thank you.
Great, sir. Congratulations. Best wishes to you. Thank you very much.
Thank you, sir. Thank you, sir.
Steve, sir, if you can share your LinkedIn profile with scholars if they want to get in touch with you for anything, it would be a great help. I have Alice ma'am
Absolutely,
also. I
yes.
think she's also from the same industry. Yes, Alice ma'am.
Dr. Latika, thank you. And to our presenter, Steve, we want to say a very big thank you for a great research done and a great conclusion. When I looked at your statistics, I want to ask, what were the challenges you encountered in getting data for this very amazing research that you presented, so that you could also be a source of encouragement or resource to us to also use in pushing as we are also undertaking our own. Thank you. My humble question.
Thank you, ma'am. So I must confess that we started the hospital a while back because there was a great need. So a lot of these things we've been learning along the way. And for me, it's part of why I enroll in the DBA class in IIBM, so that things will make sense from a business point of view. All along, I've just been, a practicing gynecologist, a practicing doctor who now happens to manage a hospital. So I needed to learn a lot of these things. So most of these things we've learned along the way. It is just our local data that we collect from the hospital and also from what patients demand from us. Because, our patients will come and they'll say, we need to introduce service, we need to do this, we need to do this. I have a very good board which allows innovation, which allows us to introduce different things, and they are very supportive. If things work, the board is happy. If things don't work, we consider it as a lesson. So it is a mixture of taking risks, learning, being innovative, and also, just learning about the theory of things.
Thank you, sir. Thank you so much. Very beautifully said. If it does not work, we take it as a learning lesson. Thank you, sir. Sir, we have Johnny sir and Suleiman sir to ask your question. Any of you can please unmute.
Yes.
Hello, Doc. Let me let Suleiman go ahead first. I'll follow.
1 minute. Steve sir, you can stop the share of your screen as you are answering, because I'll need
Thank
to
you
take
very
attendance.
Thank you very much, Johnny.
Thank you, sir.
Good evening, Dr. Latika. Good evening, Dr. Steve. My question, what's your experience about utilizing AI through the hospital? There is any usage of AI through the hospital? There is any experience? Thank you very much, Dr. Steve.
Thank you. Thank you, sir. Interesting question. My thesis was actually on AI and marketing under the supervision of Dr. Latika ma'am. And initially, if I can just give a very practical example, is that we had traditional marketing. We had billboards, which we were spending a lot of money on. And I wasn't sure if it was working. And when Dr. Latika ma'am suggested that I need to solve a market problem, then I decided to just have a look at to do a survey and see if traditional marketing is working, and just to throw in social media and AI algorithm development as a marketing tool. And interestingly, traditional marketing in my setup is a waste of money. All my respondents, about 80%, says they don't look at billboards, they don't listen to the TV, they don't listen to radio, but what they listen to is social media, and social media has a lot of AI and precision marketing integrated in it, which was very interesting for me and for my managers and also for my board. And of course, I was conflicted because I thought this is what worked. As a millennial, I thought this is what worked, but I realized that it does not work from my study. So the experience that I have so far of AI and precision marketing is that it works. Traditional marketing, if you want to throw around some money, then you can do it, but it does not work as well. I hope that answers your question, sir.
Thank you very much. Very clear.
Thank you, sir. If you can take Johnny sir's question. Yes, Johnny sir, please.
Yeah, thank you very much, Dr. Latika, for bringing in Dr. Stephen. Doc, I must confess that I admire that your composure, the steadfast presentation that you've done for us. I admire that you. Thank you so very much for that. I must confess I'm a novice in the medical field, but I've got an interest in the business area of it. I'm working with an institution that is interested in kind of building medics, and I happen to be in that area in the management field of the college. So I learned a whole lot from your presentation. And well, Dr. Latika has already proposed that you share with us your LinkedIn through the chat box here so we can get in touch with you. I'm interested in the business area, basically. And also on your presentation, the areas that have to do with the promotional aspects of the business, there are things that I want to learn from you. Thank you so very much once more. Thank you, Dr. Latika.
Thank you. Sir, I'll just disable the chat box so you can share your ID. I have Michael and Chidi sir to ask you something. Yes, Michael sir.
Thank you, Dr. Latika. Thank you, Sir Steve, for the presentation. Very comprehensive. I suppose my question is just simple. Public sector or private sector? What is best for the health service, in your opinion?
Interesting question, sir. In my part of the world, there is a place for each. The public sector, the government, is obviously big brother, has all unlimited resources, can make rules to govern the system. But the private sector has innovation, has less bureaucracy, is actually very versatile in terms of making quick decisions, very rapid decisions in terms of technology adoption. So there's a place for each. I think in my country, it's about maybe 60-40. 60% of the patients seek healthcare in the public sector, but 40 in the private sector. But in terms of the complexity of what is done, there's more in the private sector than it is in the public sector. So the public sector remains pretty basic. And the public sector is more advanced in terms of what it can do.
Thank you very much, sir.
Thank you, Michael sir. Yes, let's take the last question with Chidi sir. Yes, Chidi sir, to you.
Thank you, Dr. Latika. Thank you, Dr. Steve, for your time. Reminded me of some time that I spent in Kenya, just listening to you. So I'm looking at it from a marketing and pricing and profitability point of view, right? How do you market so that you can then, I think my question is, how do you focus on the type of patients in this case, which is customers, if you like, so that you can then look at whether you are charging premium rates or what kind of patients do you, so that looking at the profitability plans or forecasts that the hospital have, is it based on the location or is it based on the type of services that you provide?
So for me, I wear two hats. I'm a clinician, I'm a doctor, and of course the human helping part of me sort of sometimes takes over. But also I'm employed by a board. I'm also a shareholder and a businessman. So I'm also interested in the business aspect of it. That said, the fact that we are located in a rural place then means that we do not have too much option in terms of charging too high, because otherwise there'll be no advantage for our patients to remain in Nakuru. They would rather go to to Nairobi, the capital city, where things are already expensive anyway. So it's a delicate balance of keeping our patients here, making a point for the shareholders and the business, but also providing local care. And that balance is extremely delicate. So our prices are obviously not as high as a big city, but also we need to price them sort of premium for our location so that there's no perception that they are poor quality, because in this part of the country, if a price is too low, it is considered to be poor quality. If it's a bit high, then people associate that with good quality. So it's a very delicate balance, and so we have to keep just juggling between those two. I don't know if that answers your question, sir.
No, thank you so much. I can see so location plays a role, but you still need to try and maintain the standard of the services that you provide. All right.
Absolutely.
Thank you.
Thank you. Thank you, Steve, sir. I have Dennis, sir. Yes, Dennis, sir, please go ahead.
Yes, thank you, Dr. Latika, for inviting me for this great corporate talk. Thank you, Dr. Steve. Really, it was really nice and to discover. I'm not in the medical sector, but I was thinking about particularly for the rural part, because in Africa, I think that there are things maybe I don't know if we can develop it. Maybe I need your expertise to tell me more about it. I've seen much more in Europe, in France particularly, that there has been development regarding the rural area, that they can do some part of it can do online consultation regarding medical part. That is, someone can go through something that is online, which means that technology is getting into it, which means that there are some part of online. Is this realistic, or and also it can be not of great cost, not as expensive as it can be, to set up a hospital in the rural part. In the meantime, do you think that something like a service, online services, can be something realistic in Africa? Because I've seen that in France, in England, they are trying to do something like that. For some maybe I don't know, I would say very soft, when someone maybe is having a high fever, he can have something online. I don't know, do you think it is something realistic that we can in the future? Because I'm pushing you in the future, and particularly for the continent Africa, because I love Africa. That's why I'm asking that question about it. Thank you very much.
So it's certainly possible. It's certainly happening. It's important to differentiate between two very large issues. The first one is medical. And for medical, it is where you give me your symptoms. I will do a mental algorithm and decide, you're having malaria, you're having, bacterial infection. Then I will tell you, take this medicine, take this medicine. That will certainly work. The problem comes where, and this is pretty old school, where we need to examine you. So that if you tell me you are having pain on your hand, then I need to just pinch and decide, is this a bone issue? Is this a nerve issue? Is this, so online consultation then is not able to do that. It is certainly not able to do for things like maternity, and obviously not able to do that for surgery. So it's able to do a mix of medical, which do not require examination and they don't require surgery, but it can be done for the others. So very big issue about this is that how we can circumvent it is to have a network of, let's say, nurses or paramedical staff or even the young doctors located in a certain place, and they can examine and report to a senior specialist about certain things because they are more trained than a layman. So if they examine, then and you press, and a young doctor can tell you, no, this is bone issue, there's a fracture, or this is a nerve issue. There's no fracture, there's pain, so it's probably a nerve issue. So if it's linked to a local provider who might be a bit junior, then it is possible for that to happen.
Thank you. Thank you, Dr. Steve. Since we are running out of time, we have a single minute. So Dr. Steve, firstly, thank you for making time for me and coming here. So on behalf of everyone present, thank you for delivering such an insightful and engaging session today.
Thank you, sir.
Definitely, your valuable perspective and practical experience have greatly enriched our understanding and inspired our scholars for sure. I sincerely appreciate your time, support, and contribution to our learning community. Thank you.
Thank you, ma'am. It was a
Dr.
pleasure. It was a
Steve.
pleasure. Thank you.
Thank
ma'am.
you.
Thank you, Dr. Latika.
Thank you,
Thank you.
Dr.
Thank you very much,
Dr.
Dr. Latika.
Latika.
Thank you,
Thank
Dr.
you
Stephen.
Thank you,
so
Dr.
Thank you,
Steve.
Dr.
Thank you,
Steve.
scholars, for being here.
Thank
very,
you. Thank
Julie.
you.
thank you.
Thank you.
Thank
We
you,
appreciate
Thank you so
Dr.
much.
Good
Latika.
night,
God bless
everyone.
you.
Good
Good
Bye.
night.
night, Dr.
Thank
Thank you,
you.
Dennis,
Latika.
for being
Bye-bye.
here. Thank you. Bye-bye.
Bye-bye.
Bye.
Thank you, Dr. Steve.
Thank you, ma'am.
Thank you, Dr.
See you
Steve.
tomorrow, Dr.
Thank
Latika.
you, Dr. Steve.
Sure.
Thank you, ma'am.
Scholars, I'll see you all tomorrow. Stay
Thank you,
blessed,
ma'am.
stay happy, keep reading, happy studying. Bye.
Thank you, ma'am.
Welcome.